Hello dear colleagues, today we are going to talk about herpes zoster. Definition: herpes zoster or shingles is an intraepidermal vesicular eruption occurring in a dermatomal distribution. It is caused by the reactivation of latent Varicella Zoster virus in people who have had varicella. Herpes zoster grouped cloudy and hemorrhagic vesicles on a red base in a dermatomal distribution. Incidence: some 30% of individuals develop herpes zoster during their lifetime. 2/3 of these individuals are older than 50 years. The attack rate is age dependent, with a rate of 1 case per 1,000 among healthy people less than 20 years old, 3 cases per 1,000 in patients between 20 and 49 years old, and a peak of 11 cases per 1,000 at age 80 to 89 years. Patients with cancer and AIDS have a higher incidence than the general population. Example: 8% to 25% of patients with Hodgkin disease develop herpes zoster. The frequency of second attacks may be 5%. However, what is thought to be recurrent zoster may be HSV in a dermatomal distribution. Note: vesicular dermatomal eruption is distinctive for herpes zoster. History: a prodrome of radicular pain and itching precedes the eruption. It can simulate migraine, pleurisy, myocardial infarction, or appendicitis. Physical examination: the eruption is characterized by groups of vesicles on a red base situated unilaterally along the distribution of a cranial or spinal nerve. Bilateral involvement is rare. Frequently, the eruption involves the immediately adjacent dermatomes. Differential diagnosis: the dermatomal distribution of herpes zoster is diagnostic. However, herpes simplex may occur in dermatomal fascia. Laboratory and biopsy: usually no laboratory tests are necessary. The zinc preparation, direct immunofluorescent staining of a vesicle smear, PCR, which is most sensitive test, biopsy and culture are confirmatory in unusual cases. Although herpes zoster has a higher incidence in patients with established malignant disease, patients presenting with herpes zoster who are otherwise healthy do not have a higher incidence of occult cancer and therefore do not need a screening laboratory examination for malignancy. In patients at risk for HIV infection, herpes zoster may be the presenting sign and serologic testing for HIV is indicated. Note: herpes zoster is not a marker for an occult malignant disease. It may be the presenting sign of an HIV infection. Herpes zoster in epidermis, bulla, and multinucleated giant cells can be seen, and in dermis, perivascular inflammation is present. Therapy: prevention with zoster vaccine recombinant adjuvanted is very effective and indicated in individuals older than 50 years of age. When the vesiculopustules of herpes zoster rupture, crusting and weeping are reduced with astringent or dermatological analgesics commensurate with the amount of pain experienced by the patients are indicated. Acyclovir at a dosage of 10 mg per kg every 8 hours intravenously or 800 mg 5 times daily orally for 7 to 10 days halts the progression of herpes zoster in immunocompromised patients and is most effective when started within 3 days of the beginning of the eruption. The effects include less cutaneous and visceral dissemination, cessation of new vesicle formation, and reduced pain. The modest benefit of acyclovir, valacyclovir, and famciclovir for otherwise healthy patients may not justify the expense except in severe infections and in patients older than 50 years of age to reduce postherpetic neuralgia. The use of corticosteroids in otherwise healthy patients to prevent postherpetic neuralgia has been advocated but has not been convincingly proven to be worthwhile. amitriptyline at a dosage of 50 to 100 mg daily, or gabapentin 100 to 300 mg 3 times daily may be helpful in managing postherpetic neuralgia once it occurs. Capsaicin analgesic cream 0.075% used topically 3 or 4 times daily on affected skin can also provide pain relief. Caution must be maintained to avoid inadvertent contact with the eyes or unaffected skin because capsaicin normally produces transient burning. Foscarnet is indicated for resistant herpes zoster. The conclusion of therapy for herpes zoster prevention include zoster vaccine, initial therapy with antivirals like acyclovir 800 mg 5 times daily for 7 days, 10 mg per kg IV every 8 hours for 5 to 7 days, or valacyclovir 1 gram TID for 7 days, or famciclovir 500 mg TID for 7 days. Compresses with aluminum acetate and pain medication like analgesics, amitriptyline 25 to 100 mg at bedtime, or gabapentin 100 mg to 300 mg TID. Alternative therapy include foscarnet 40 mg per kg every 8 hours for 10 days. Course and complications. The succession of lesions begins with macules which develop into vesicles. Over the next several days, pustules develop and are followed by crusting and eventual healing in 2 to 3 weeks. Hemorrhagic bulla and gangrenous change may occur and may result in scarring. Cutaneous dissemination of herpes zoster from the original dermatome develops in some patients, particularly immunocompromised patients in whom the condition is more likely to be severe and prolonged. It occurs within 5 to 7 days of the initial eruption and may be accompanied by fever, malaise, and prostration. The immunocompromised patient is susceptible to visceral involvement of the liver, lung, and central nervous system. Postherpetic neuralgia is uncommon in patients younger than 40 years of age, but 27%, 47%, and 73% of untreated adults older than 55, 60, and 70 years of age respectively develop this complication, which is frequently difficult to control and very troubling to the patient. Besides older age, the risk of developing postherpetic neuralgia increases if you are female, have a prodrome, and have more severe acute pain and eruptions. However, 80% of patients with postherpetic neuralgia become asymptomatic within 12 months. The nasociliary branch of the ophthalmic division of the trigeminal nerve innervates the eye and the tip of the nose. Therefore, herpes ophthalmicus should be suspected when herpes zoster involves the tip of the nose. Scarring of the cornea and conjunctiva may occur. Thus, this finding requires urgent treatment. Other occasional complications of herpes zoster are full thickness skin necrosis and Bell palsy. When herpes zoster involves the tip of the nose, suspect eye involvement. Pathogenesis. After primary varicella infection, which the patient often does not recall, the virus becomes latent within the sensory nerve ganglia. With reactivation, replication again occurs with the migration of the virus along the nerve to the skin. Viremia frequently occurs, sometimes resulting in disseminated lesions. Clinical case. A 58-year-old man presents with a painful rash on the right side of his chest for the past 3 days. He reports that the pain started as a burning and a tingling sensation in the ear about 2 days before the rash appeared. The pain is severe and localized. On examination, there are multiple group vesicles on an erythematous base distributed in a unilateral band-like pattern along the right thoracic dermatome. The lesions do not cross the midline. Some vesicles have started to cross without mucosal involvement. What is the most likely diagnosis? A. Herpes simplex. B. Contact dermatitis. C. Impetigo. D. Dermatitis herpetiformis. And E. Herpes zoster. According to our explanations, the correct answer is herpes zoster. Explanation: the conclusion of herpes zoster include herpes zoster or shingles is caused by reactivation of Varicella Zoster virus. As we explained, key features include painful prodrome, burning and tingling, grouped vesicles on erythematous base. As we explained, dermatomal distribution is important, unilateral and does not cross midline usually, which is very important and common in older adults or immunocompromised patients. Differential diagnosis: herpes simplex is recurrent grouped vesicles, usually perioral or perigenital, without a dermatomal distribution. Contact dermatitis is pruritic rash with exposure history without dermatomal pain, and impetigo is honey-colored crust, usually painless. Dermatitis herpetiformis, which is intensely pruritic grouped vesicles on extensor surfaces associated with gluten sensitivity. Okay, this was an explanation about herpes zoster. Thank you for your attention.